previous talk. It's not moving. My financial interest. So these are all what has been discussed since morning. The most biggest challenge today is about subclinical dry eye, because dry eye, when you know, it's very easy to pick up through the this. It's a challenge because we do not have a precision medicine if you're not able to diagnose properly about the concepts behind what is happening to the dry eye issues. It's an age of immune mimicry. If you look at the last 5 or 6 years of Nobel Prize being given in physiology and medicine, most of them is driven at inflammation and role of inflammatory cells, including this year, it's about T lymphocyte, the T regulatory lymphocytes. Today, irrespective of how skillful you are or how good you are with your technologies, we are able to predict only about 80% of the time patients being happy. I'm not talking about the outcome in terms of metrics of outcomes. I'm not talking about your plots of safety efficacy. It's about being happy. When you say not happy, it's about everything to do with the optics and majority to do with the state of ocular surface. So what are the unpredictable outcomes? Dry eye, neuropathic pain, epithelium being irregular, refractive surgery. You have ectasias, which is not predicted by your topographies. So what makes it to be unfavorable? It's your altered immune profile. So these things I'll skip, already discussed about it. And the most important thing which makes it unpredictable is your cell signaling. And how does the cell signaling have an impact on everything what you do? And as mentioned by my previous speaker so beautifully, you can see that if you look at from the early 2000 to now, 2025, including the publication and including the work and interest, has been so exponential growth in the way people are showing interest in biomarkers. In the first DUCE report, we did not have any space for anything to do with inflammation or biomarkers there. And second issue had a lot of, it had some talk about biomarkers. And the third talks significantly about role of why we need to implement in our practice. So how did we work on it? One is to see if we can bring those biomarkers to practice. It's not possible to bring everything what my previous speaker said about lipids and proteomics, because you need a different platform. It's easy to do a point of care when you're doing with an inflammatory platform, and it's quite complicated when you try to do a proteomics or lipidomics or metabolomics in it, because you need a different set of tools for that. So what we thought using AI is can we use indices to identify biomarker in the cohort and cutoff? What's the cutoff in different population and gender? Because women's biomarkers may be different to a man. And because many cycles of your hormones would change the biomarkers. In the most ovarian phase, your biomarkers are different. You have more of MMP9s in your ocular surface. How you standardize this? How you collect it? Like she said, do you collect with your fingers? Initially, when we are collecting tears with the fingers, our tears, the oil secretion would also impact it. So how you started looking at it? So we started the work in 2008 or 9. That time we were collecting a lot of these samples, loads of them. And we created one of the largest repository of dry eye in the world. We had Schirmer strips of more than 10,000 patients being collected. Then we decided that is a very cumbersome and laborious process for the lab to keep doing it. Why not bring it to your clinic? It's like taking an insulin test, a blood test, to a small, your glucometer at home. So we thought if we can do it. And that became our whole concept of the biomarker kit, where we started. This is the first commercially available, which will be commercially available in next year, but commercially available one which looks at multi-panel evaluation, most of it what was seen in the chart, what Dr. Helena has mentioned. So what do? It's done in outpatient. You take a Schirmer strip, like you do your dry eye. and collect it in the Epindrop tube. You use a leaching thing which leaches out the proteins. It's a buffer. You shake it well. Now you have a machine to shake it because you need to leach it out. Put those into those cartridges there. Put it in this machine which runs the microfluidic ELISA test. And at the end of it, 90 minutes, you look at these markers and what you get is this report. What you get is these report, and it's important because these now have a color coded. This is an AI driven one. It's got an AI of close to 9,800 odd samples. The machine has already identified what is predicted and what is subclinical. This is important because if you're doing a cataract surgery, if you're somewhere here, you're betadine and your paracrine pushes you to this side because inflammation of betadine and paracrine pushes, so your patient becomes less happy post surgery. The same thing can be got from, we can put vitreous also, you can put trabecular meshwork, you can put CSF, you can put blood, but we had to create a normative data of each one of them. So we have 8,000 vitreous samples of diabetic patients, 3,800 of ARMDs, vitreous, and they all have something similar report which tells you what is working. For example, in diabetic retinopathy which doesn't respond to your treatment, the most common culprit is the ICAMP1, and we need to use a different drug for that. So how do I use in my practice? Using this, I can use to titrate. This is not a perfect one. We are trying to perfect it, and the future generation of them will start looking at which drug will work, like your antibiotic sensitivity. The machine itself will try to identify it. It tells you, looking at your epithelium, you correlate this. It tells you that irregular epithelium has more TNF alpha, which is high, or the ICAMP1, which is high. IL-10 is an anti-inflammatory cytokine. That means it is not a pro. If it's high IL-10, which is high here, it means it's good for you. That's a very interesting thing is not always you're looking at only bad ones. Nothing is bad in the body. Even MMP, if you don't have MMP9, nothing is going to heal in your body. It's only that excess of them is bad. And in this case, all of them are high, but IL-10 is also high, which means it is protectant to you. But sometimes if it's low, it means that it is not good. That's the most important thing about it. We treat them sometimes. You know whether the treatment is working or not. This patient is posted for a cataract surgery. He has a lot of dryness. You're worried about him becoming unhappy after surgery. You want to put a multifocal lenses. You treat him with, say, cyclosporin for 2 weeks, and it's come back to this zone here. From a subclinical inflammation, you pushed him back towards the normal thing, and that's what you can do. And this gives you a baseline how you can treat. And somebody who is somewhere here but still pushes them back, that means that is not good yet, especially if you're doing a PRK or any treatment. We can try with different cyclosporins. We tried 0.5 and we saw when does it improve. You can use different drugs to see if you use these drugs, will it change the markers. I'm not saying these are the only markers. I mean, what she showed was phenomenally big list of it, but we had to start somewhere. We had to start from zero somewhere. It's like doing the first blood test of HBTC or something like that. We are in that stage now. I use this a lot. This has all been published in scientific report. If you have a high level of IL-6 and TNF-alpha, this would end up in chance of more PRK or cross-linking scarring. So you can actually predict it and actually pre-treat them. We use the word biological cleansing, which we have submitted for a publication where you try to treat them before you do any procedure, because you can't treat them after surgery. And this is what works well. IL-17 is a very important molecule because IL-17 has a role in neuropathic pain. IL-17 has a role in microneuromas. If you have microneuromas, IL-17 is one which is secreted a lot. So a lot of people ask what works very well is the IPL therapy, because IPL therapy, one of the things it does is it drops down the interleukin very well. And the second place where IL-17 has been implicated a lot is poor recurrent erosions in your eye. When somebody has multiple erosions, because the hemidesmosomes, the contact junction becomes very poor. So that's again one of the areas where the IPL therapy works well because it drops down immediately. Or the third place is you are doing a PRK and your epithelium is extremely irregular and you're worried about the challenges of having haze. Again, IPL therapy works pretty well in this because this is what we've been working on it and some of it has been published also. So it also gives you, this is an older report. We did not have AI then. It just tells you in values itself how the values changes with highlight. I know financial interest in it, but it just tells you the MMP1, TNF, ICAMP1s were very high. This is a patient with neuropathic pain. And by the third sitting, you can see that it's changing. So it helps to titrate if your treatment is actually working or not. This case is very important to me because this happens to be one of my colleagues' son. He wanted a PRK surgery done. I posted for PRK. He had conjunctivitis and he improved. As soon as he improves, they came back to me and said, everything is fine and he wants a surgery. Because he's traveling out to US and I will not be seeing him, I was concerned about whether it's completely healed or not, because his eye is completely healed. There's nothing which symbolizes, nothing which says that he had any infections. So I did the tear assessment. His left eye was a bad eye which infected, and the left eye, look at where the inflammation is. It's here. And where is the right eye which did not have anything? It's on this bottom here. Now, this person is for PRK. So let's assume that many times we get this kind of patients. We operate on them. Everything is good, but one eye behaves differently than the other. One. Or second is, after 3 or 4 months, they develop bad haze, or he develops neuropathic pain or some vague thing. Technically, this is what we have published also in scientific report. His TNF-alpha, IL-6, and IL-17, all three implicated in corneal scarring, post-PRK and cross-linking, are probably at the, there's the dead end of what the upper limit is. That means, if I had operated on him, 3 months later or 4 months later, he would have developed a chronic late-onset corneal haze, and we would be worried what really happened because we'd be blaming sunlight, nutrition, multiple other things. So what did we do for him? What we did was, this is what I explained. These are exaggerated responses. These are what happens in the normal thing. Your keratinocytes becomes fibroblasts, and they come back to normal status very quickly. And everything happens very quickly. The whole recovery cycle becomes very quickly. But the job of a keratocyte, the whole job of MMP9 is to try to make it better. It's actually a very, very protective. That's why metallic metalloproteinases is a recovery once. It's remodeling. It doesn't allow it to become scar. But when it's more, that's when the whole problem starts. And this is what would have happened to this patient. This is what would have happened to many of my patients in the past when we probably did not understand this. And this can happen to your cataract patients. They are normal. So suddenly they become dry eye post-surgery, or they start becoming pain or multiple other things. Because these patients have so much of these MMPs that they never recover. They never allow them to recover. So it's maintaining them, checking them before surgery helps to avoid something which probably we would have never looked at it. And I treated him with a small dose of steroids because it's an acute phase. So I thought that I would use a lifitegrast, that would work much faster than cyclosporin. And he got better. Then I did his PRK and then healed. Sometimes you see patients, PRK patients or cross-linking patients, you do the surgery, they never heal. The epithelium takes a long time for it to recover. And what we found is they have extremely high level of IL-17 in them. For some reason, and high MMP9, some reason it never allows to heal. I'm sure there are many hundred other things, but I'm talking about what I can check. And when I see those high levels of it, it's important for me to understand that this person may have a slower healing. It happens especially with post-cross-linking. To summarize, the AI in biomarkers makes it simple, but this is from one geographical population. Tomorrow, somebody wants to use it in US or Egypt. If you add your data, the machine has a self-learning potential to create your normative data. And what is important is you have to normative data for male and female has to be looked at it, because different cycle in a woman's cycle of hormones, the MMP changes. And that is the most important thing, which we published it also in one of the journals. It helps to discover and stratify. This is just the beginning. I'm sure there are hundreds of which is mentioned, which needs to be looked at. And we can keep adding more and more panels to it. It helps to target your treatment. You become a thinking surgeon. You're not shooting in the dark. It's not like for everything it happens, you blame the skill or machine or treat them with steroids. A lot of these things don't get treated with steroid. IL-17, very difficult for the steroids to work. And it helps to look at new drugs. For example, a company comes and tells you this works for this patient. You can see if it's really working. And it helps you to start thinking out of box. For example, non-healing epithelium, can we use an IPL therapy or can I use insulin drops? When I use an insulin drops, insulin also improves a lot of, it's a growth factor. It changes a lot of this. And what is, I feel, the major area of interest, we just published a paper in American Journal of Ophthalmology, where we looked at close to around 35 children who showed aggressive myopia. There were 85% of them had high level of inflammation without any dry eye. So it is important to look at myopia as a white inflammation, where there is no inflammation which you see, because we believe in the cardinal rules of Greek cardinal signs, pallor, rubor, loss of function, calor. But white inflammation is where you see the subclinical thing. And the children, I feel, and then we started looking at multiple roles of inflammation. And what is interesting, we just again submitted a paper, the dopamine receptors are the most important receptor, which I'm going to speak in the afternoon, which prevents the myopia from progression, because dopamine works on the scleral fibroblasts. It allows the fibroblast not to elongate, so it becomes myopic. So one of the first thing which gets knocked off from the eye in myopia is dopamine receptors. Why? All the molecules I said and what Professor Helena said knocks off the dopamine receptors from the ocular surface and the whole surface, and that is one of the major reasons why myopia may be progressing. So as we keep moving, we may have many indications of role of biomarkers, not just in dry eye, but multiple other places. And this is a summary which I've already explained. Thank you.
Thank you so much. It was a great lecture. Now we have 10 minutes of discussion. So I'm going to the very precious panel here. Dr. Hani Sakla, would you like to comment on the talks?
Actually, I'm very impressed by your presentation, because it explained to us and to many, of course, of my colleagues, when we are intrigued in front of a patient with successful cataract surgery without any signs of inflammation, but still with persisting pain. The role of IL-17, as we learned it today, is the key. So do you recommend using the leftigrast for patients with pain after successful cataract surgery without signs of inflammation, even if this pain is persistent for from the beginning of the surgery for a few months?
Ocular pain, when we looked at all the ocular pain related pathways, there are many of them which we may have not looked, maybe somebody else has looked, but they all form in IL-6, 17 and these factors, IL-1 beta, one of the major factors. The lifitegrast works on the cell surface. It blocks the ICAM molecule from shaking hand with the T lymphocytes, which it has a receptor called LFA. We call the handshakes. So when the ICAM molecule and the T lymphocytes meet together, they handshake. When they handshake, it's like a suicide bomb there. It releases all kinds of inflammatory molecules. One of the molecules is the IL-17 and all of them. So lifitegrast blocks that handshake completely. Cyclosporin doesn't do anything on that. It goes in the cell, and whatever those molecules are, it goes into the nucleus, and there it stops it from replicating. So lifitegrast works much faster on the surface. And lifitegrast has a very good role in the ion channel modulation. The entire problem of ocular surface pain is not just inflammation, it's about how you modulate ion channels. That means if you look at two sets of people, one with dry eye, use poroparacane or betadine in them, there is 80 to 90% increase of inflammatory mediators, which subsides over time. In many patients, it doesn't. But what changes in them is the ion channels. So betadine has a very, very small role in increasing the nociceptive potential of a patient. That's why if you have a patient who has a dry eye or ocular surface problem, you have to pre-treat them with, say, lifitegrast or cyclosporin or this therapy, dampen their response so that even if you use betadine or proparacaine, it will not offset that ion channels. And use of IPL or lifitegrast post-surgery is very good, but post-surgery you have created a tsunami. It is so much of a tsunami that it will take a lot of time for it to start working and acting on it. So one very good indicator for if you have a problem is if you look at your epithelial maps, which a lot of cataract surgeons don't see. If your epithelial maps is filled with different colors, it means your ocular surface is also unhappy because you have one area which is red, one area which is yellow, and there is a lot of hyperplastic epithelium. We have correlated that very well with the corneal nerves and the T lymphocytes. That will give you an idea that whether you have to start something preoperatively or not. Otherwise, you can use it, or you can use the judgment based on your mebography and other.
And the IPL, how is the mechanism to reduce the interleukins?
The exact mechanism is little different, but it works on the vasculature. It has that the red modulation works on the vasculature, but it also has a huge impact in the way the eye responds to the treatment. So if you ask me, we also written in that paper that we have given hypothesis, but not an exact mechanism.
Okay, thank you. And what would you like to add, Dr. Ji?
Well, I want to thank you all for your presentation. That was really rich and enriching. I have a question for all of you. If I could understand the meaning of the aim of all those innovation and technology was, for me, to transform this disease, this wide and this broad spectrum disease, into a scalable one, so we can have a management based on the stage-based management. So is that true or no? That's my first question. And my second is, do you have any experience about the in vivo confocal microscopy in goblet cell density in the conjunctiva?
To look at goblet cell density, you need an impression cytology, and that would give you the proper one. Confocals don't pick up very well on this. Cornea, you don't, but you can pick up some abnormal cells and surrogate indicator. And the second answer, which I will tell, then I pass the mic on, is any innovation has to be clinically relevant for people to use it in the practice. So that is the way we wanted to work on this biomarker kit, that next year when we launch it, it should be in your clinic and you should give a patient the report like how you would give a blood test report. And you should be able to plan your treatment based on that. And maybe in 5 years down the line, that panel should increase to 25 more cytokines or proteomics.
Thank you for the question. I would like to emphasize the need that the clinician has to have this kind of tools, these biomarkers, and all that we can use at the clinical setting that can help us decide more absolutely with data that we don't have, and we still go a lot of the times by empirical experience, and I learned a lot, and I enjoyed a lot seeing that the evolution, the progression that we can do at the clinic. Even, for instance, for impression cytology, it can be a little bit of a struggle to have this bridge with the pathologist, and they have someone interested in developing this. So it's very difficult, and it's still, I think, it's despite having access to insulin, to autologous serum, and etc. We see cyclosporine A. It's still we still are very much attached to the empirical experience, and we really this type of progression to go very quickly to the clinic, to be, you know, just do it in the office very easily. As we read, as we learn, it's very important when we still lack this. And this is my experience. So it's something that we have this call, and it can be a lot of difference. For instance, in the case that Professor has presented. But these examples are I think are very key examples to show how these ancillary tests are so important in terms of the outcomes of the patients, and this might be something that will help us to develop and you know, just appreciate and validate this. So thank you. Yeah, please, Dr.
Thank you for really exciting lectures. And I think that now we're discussing, and we are in period that in future this is it will be precise in medicine in dry eye disease management, and it's a big step. Thank you for this. And I have to some extent provocative question, because we discuss a lot of imaging technologies. And what do you think, dear speakers? Is it already the era when we can forget about Schirmer test as a marker of dry eye disease, or we continue to use it?
We can use Schirmer test to the next step. I think
We will use it for the point of care.
No, I think that the imaging technology has its role. I think that to have objective measurements are very interesting, both for the doctor, but also for the patients. Because, for example, if the patient see in dry eye disease, the symptoms are only correlated with the clinical signs. Some patients, you know, show treatment are improving her systems, but if we show him that there are an objective improvement, for example, in the non-invasive TBOT, this patient is easier that the adherence to treatment will be more than if they not feel any improvement with the treatment. So I think it's important not to have objective measurements. Everyone knows that for check the macula, you use an OCT, and it's completely normal. So why don't use technology, imaging technology for the ocular surface disease? I think is interesting. We are using in our clinic in the unit of dry eye the keratograph and the LipiView, and I think are very interesting in order to guide the treatments also. And depending on the severity of the dry eye, I think is interesting.
Thank you for touching. I think also from my experience, it's a very important aspect that is patient education and explanation what the situation is about, and having it's incredible how this can completely alter the compliance of the patient to the treatment and the outcomes that we can have. So explaining and having some measurements that are objective to show that, I think it's very important.
Thank you so much. We are getting running out of time. So we are closing this session and we have 15 minutes of coffee break at the exhibition hall. Please come back after 15 minutes. So we will go on with the nice lectures.